So next is colorectal. The first topic is intestinal failure. Intestinal failure encompasses a spectrum of conditions that manifest itself as inability to maintain nutritional, fluid, and electrolyte homeostasis without supportive therapy. And there are two intestinal failure units in the UK. One is St. Mark's Hospital in London, and one is the Hope Hospital in Salford, Manchester. The intestinal failure criteria, there are 8 points. Number 1, persistent of intestinal failure beyond 6 weeks without any evidence of resolution or complicated by venous access problems. Number 2, multiple intestinal fistulations in a totally dehiscent abdominal wound. Number 3, intestinal fistula outside the expertise of the referring unit or second and third occurrence in a colorectal center. Number 4, total or near total small bowel enterectomy resulting in less than 30 centimeters of residual small bowel, 30 centimeters between 1 foot. Recurrent venous access problems in patients needing sustained TPN, and this definition includes recurrent severe infection, the recurrent venous thrombosis where all the upper limb and cervical venous access routes have become obliterated. Number 6, persistent intra-abdominal sepsis complicated by severe metabolic derangement that is not responding to radiological surgical draining of the sepsis and provision of nutritional support. Metabolic complications leading to the high output fistulas and stomas and to prolonged intravenous feeding not responding to medication and adjustment for the feeding regime if they have a hepatic or renal failure due to the TPN. And the last, chronic intestinal failure in a hospital without adequate experience, expertise to manage the medical, surgical, and nutritional requirements for such patients. So causes they have defined into 4: loss of intestinal length, like surgically we resect, or loss of functional intestinal length, loss of intestinal absorptive capacity, and loss of intestinal function. And then is the pathophysiology. Intestinal, there are 3 stages of intestinal failure. Number 1 is stage 1 hypersecretory phase, and it remains 1 to 2 months. And then is adaptation phase. This remains from 3 to 12 months. And then there's a stabilization phase. It remains 1 to 2 years. And then they mentioned about fluid, electrolytes, nutrients, adaptation. So the movement of sodium into the lumen occurs if luminal sodium concentration is low. That's why we ask the patient to not drink low concentration fluids. If luminal sodium concentration is low, and absorption of sodium and hence water occurs only when the concentration is greater than 100 millimoles. So they should drink water who has concentration 100 millimole. And then nutrients, adaptation. So surgical, catastrophe, and management. So we have to resuscitate the patient, and then restitution. Restitution has the formula of SNAP, SNAPP, double P. So one is sepsis, so you have to control the sepsis, and second is nutrition, and they mention that patient have a strict intake and output, and whatever water losses are coming, we should give them fluid and electrolyte replacement should be by the intravenous route with the following requirements: water losses plus 1 liter, and sodium losses, and they consider 1 liter of stoma output has 100 millimole of sodium plus 80 millimole daily requirement, and potassium is 80 millimole per day, and magnesium is 10 millimole per day. And then nutritional support, and then is the and if someone has in nutritional support, if there is colon present, then they need complex carbohydrates, fat, and protein, and the energy level needs 30 to 35 kilocalorie per kilogram per daily body weight. And if colon absent, then they need again 30, the same. So reduction of output, so they have mentioned that first of all we should tell the patient to increase the oral, decrease the oral, limit the oral intake till for 500 ml. And then we can give either them St. Mark solution, which can be made at home with 4 spoons of salt, 4 spoons of sugar, 1 spoon of salt, and sodium bicarbonate. Or we can give WHO organization, or we can they synthetically diurolide. Then we should start H2 blockers, PPIs, and then we can start anti-motility drugs. Ask them to take them 30 to 60 minutes before their meals. And then dietary modification and aims and monitoring. So we should aim that there's a general rule of thumb: if someone has a stomach output less than 1.5 liter, they might be managed with oral replacement alone. If there are losses between 1.5 to 2 liter, they require sodium and water replacement, usually as subcutaneous or IV. But no parental nutrition, and losses more than 2 liter, they will need parental nutrition as well. So less than 1.5 liter, oral treatment. Between 1.5 and 2 liter, only sodium and water IV, no need of TPN. If more than 2 liter, then TPN. And we aim that patient should have less than 2 liter from the gut loss and more than 1 liter urine, and we should check the urine osmolality. If it's 20, if urine sodium is more than 20, this is our target. Serum magnesium should be 0.7 millimole, and body weight which should be within the 10% of the normal weight. So complications of intestinal failure: early, intermediate, and late. Early: dehydration, hyponatremia, shock, and hypokalemia. Intermediate: morale, weight loss, immune compromise, peptic ulcer, gastroesophageal reflux disease, proximal small bowel inflammation, diarrhea, bacterial overgrowth, and peristomal excoriation. And late: vitamin deficiency syndrome, growth retardation, depression, uh, parental nutrition induced liver disease, recurrent sepsis, intravenous line related complication, cholelithiasis, D-lactate acidosis, and urolithiasis. So SN nutrition finish. Now anatomy. This is called mapping. So we can do CT or MRI enteroclysis to look at the anatomy, and then the next P is protection of the skin, and the last P is the planning. The indications for early surgery. So they say we should wait from 5 to 6 months from the first surgery, and the only indication for early surgery are drainage of pus when this cannot be achieved percutaneously, excision of ischemic bowel, laying open of abscess cavities in the abdominal wall, and construction of a controlled proximal stoma, and catastrophic anastomotic failure by exteriorization of proximal and distal bowel ends. And then in the surgery we called it reconstruction. So it all depends. So there's a table showing factors influencing the spontaneous fistula closure. So favorable: ileum is favorable. Fistula should be long and narrow fistula. Mucocutaneous discontinuity 3, and continuity of the bowel wall 4. No active disease 5, and no distal obstruction 6. Unfavorable if it's proximal small bowel like jejunum. If fistula is short and wide. If fistula has make a mucocutaneous continuity like ileostomies, stoma we create with the skin. Discontinuity of the bowel, active disease, and distal obstruction. And then the last is the rehabilitation and from bowel transplantation. So there is a criteria called St. Mark's intestinal failure protocol. So they deal these patients into 4 stages. Stage 1, establish the stability. So they do restrict oral fluids to half liter every day, achieve and maintain reliable venous access, administer IV sodium normal saline till the urine target is sodium more than 20, maintain equilibrium by infusing fluid, and sodium losses plus daily requirement, potassium daily requirement, magnesium daily requirement, and calories, protein, vitamin, trace elements. And then this is established stability. Then is transfer to oral intake, continuous intravenous maintenance therapy, slow fiber meals, antidiarrheal medication 60 minutes before meals, start gastric anesthetic drugs, start oral rehydration solution, discourage drinking around meal times, restrict the intake of non-electrolyte drinks to 1 liter daily, and encourage snacks and supplementary nourishing drinks within above limits. Consider the need for enteral tube feeding. Start oral magnesium oxide capsule. If intestinal losses remain high, start octreotide 1500 mg subcutaneous TDS and gradually withdraw intravenous therapy. And then the rehabilitation. Patient and family should now understand the physiological changes that have occurred and the rationale for treatment. Needs to be detailed stomach care for patient with high output stomas, referral to community continence service for patient with intestinal continuity and incontinence due to liquid stools, referral to medical social worker for assistance in social If intravenous therapy cannot be withdrawn because of the continuing intestinal loss is more than 2 liters, teach the patient family to perform intravenous therapy at home. And then the last stage is the long-term care, regular monitoring and review of the therapy, vitamin B12 replacement if more than 1 meter from element resected, and review other nutrients such as zinc, iron, folic acid, and fat soluble vitamins. Thank you.